Good day, everyone. It's exciting to see every one of us joining into today's webinar. Please give us 2 minutes and we'll start up. Just waiting for a few of our participants. Thank you very much. Good day, everyone. I think we can start now. We're all very welcome to today's webinar. I'm particularly excited because it's about research findings. As we all know that research findings help us in order to improve future program implementations generally. So today we're going to be learning from the post-pregnancy family planning project's research studies. I'll give us a brief about the project. The Post-Pregnancy Family Planning Project is supported by the Bill and Melinda Gates Foundation and MSD for Mothers, and they are supporting Lagos State to increase contraceptive use among post-pregnant women within the private sector. And this has actually been implemented across 236 private health facilities. So what is the post-pregnancy period? The post-pregnancy period actually commences when a woman is pregnant through 12 months post-delivery. And this phase actually is considered important as it provides opportunities to introduce women early to family planning through their frequent contact with the health system. So in the last 4 years, the project has implemented various interventions aimed at increasing access and utilization of post-pregnancy family planning services. So this webinar will feature discussions on the association between the project's intervention at facility level outcome, such as the service provider bias and quality of family planning service, as well as looking at the population level, which will feature factors influencing contraceptive ideation, intention, and use among post-pregnant women. These findings are actually critical for understanding and improving future program interventions in Lagos State. So without much ado, I will introduce Rodio Diallo. She's going to give us the welcome remarks. Let me introduce Rodio to us. Rodio Diallo is the Interim Deputy Director for the Innovation and Implementation Research of the Family Planning Team at the BMGF and leads the family planning portfolio in Nigeria. Prior to joining the foundation, Rodio worked at Population Services International, PSI, where she oversaw the launch and implementation of an integrated health program that included family planning, maternal and infant health, malaria, and social marketing programs. During her 15 years at PSI, she served as country director for Mali, deputy director for Haiti, and as country representative for Haiti, Uganda, Mali, Guinea-Bissau, and Togo. In addition, Rodio served as the intra-health chief of party for Senegal. Rodio holds a bachelor's degree from Dakar University of Technology and a master's of science in public health in developing countries from the London School of Hygiene and Tropical Medicine. Please let's welcome Rodio Diallo.
Thank you very much. Looks like I don't have access to the video unless you allow me to get my video on. Hello, can you hear me?
Yes, ma'am. We are fixing that right away.
Okay, all right. Thank you very much. I'm happy to start without the video by the time you fix the technology, or should I just wait?
You can start, thank you.
Okay, thank you very much. Good afternoon, everyone. Representative from the Lagos State Ministry of Health, representative from the Lagos State Primary Healthcare Board, representative of MSD for Mother, representative of Lagos Private Sector Health Associations and private health facility owners and managers, colleagues from GHU CCP and the consortium members, including ARF and CCSI, and dear implementing partners. It is an honor to be with you today for the dissemination of the research studies from the Post-Pregnancy Family Planning Project implemented by our partner, Johns Hopkins Center for Communication Programs, GHU CCP, and the consortium members, ARF and CCSI. This project was a result of the collaboration between the Lagos State Ministry of Health, Lagos Private Sector Medical Associations, the Bill and Melinda Gates Foundation, and MSD for Mothers. At that time, we all aligned to the strategic goal of increasing voluntary use of modern contraceptives among post-pregnancy women from the lowest quintiles in private facilities in Lagos. The project was very compelling, given that in Lagos State at that time, and based on the 2013 NDHS, almost 80% of newborn were delivered in facilities, while a high proportion of women, over 84%, presented for postnatal visits. The project tailors its approaches to meet the need of the private sector. Activities are integrated along the maternal and child health services and any contact women have with the health system. It also builds on the BMGF funded and HSDF-led MNCH grant, the Newborn Health Quality Improvement, NHQI, which focused on improved quality of newborn and maternal care around the time of birth. The research dissemination comes at a time of the project closeout. As donor resources continue to dwindle, the need for informed decision-making, especially in program design and implementation, continues to be critical. When data is available, programs make a better decision in developing services and deploying them to areas and populations of high needs, thus making the most of scarce resources. This afternoon, the project team is sharing learnings from some of the studies conducted in the last 4 years. Data-driven decision-making is crucial for improving efficiency in both public and private sector. It helps program managers understand the needs of their targets, what is needed to make a difference, the best way to deliver them, and in what doses. Database solution also helps to use past information to predict what is to happen in the future. Without data, there are a lot of risks, such as performing on false assumptions and being swayed by biases. Data can be used by programs to design interventions, enhancing performance and evaluating impact or effect. The project built the capacity of 236 private facilities on data quality and recently piloted the use of a digital platform in 20 facilities for seamless submission of the routine data on the DHIS platform, with evidence of improved reporting rate and timeliness of data submission to the LGA. Today, as we listen to this data presentation on how the post-pregnancy family planning project has improved the contraceptive behavior of post-pregnant women in Lagos State, let us use these learnings in improving the design and implementation of our programs to ensure that we address issues of unmet needs in Lagos. We would like to take this opportunity to thank the Lagos State Ministry of Health leadership for the constant support and partnership during the project implementation. Our gratitude goes to all our Lagos private sector health partner and associations who embrace these initiatives to contribute to the state's family planning goal. We thank the GHU CCP team and the consortium members, including ARF and CCSI, for the excellent work, flexibility, and results-driven approach implementing the project. Finally, we sincerely hope that our Lagos State Ministry of Health partners will leverage the key learnings to institutionalize the post-pregnancy family planning high-impact practices within the private setting, which provides services for over 65% of the population in Lagos State. Thank you all.
Thank you very much, Rodio Diallo. Now we'll go straight into the presentations for today. We have 3 panelists, and I'll introduce each one briefly. Our first panelist will be Professor Stella Babalola. Stella Babalola holds a PhD and is a professor and teaches health communication in the Department of Health, Behavior, and Society at the Johns Hopkins University, Baltimore, Maryland. She is the director of the Research and Evaluation Division at JHCCP. She has more than 30 years of experience in behavioral research and has worked extensively in Africa, Latin America, and the Caribbean. Over the past 5 years, her research has focused largely on malaria, family planning, and the risk factors for HIV in Africa. Our next panelist is Akishewa Akiode. Mr. Akishewa Akiode is the Regional Advisor for Research, Monitoring and Evaluation at the Research and Evaluation Division of the Johns Hopkins Center for Communication Programs, Baltimore, Maryland. He is trained in statistics and public health with more than 20 years of experience in designing and implementing complex M&E systems and research activities. Mr. Akin has supported and implemented research and evaluation activities in the East, South, and West Africa. Over the last 10 years, his work has focused on use of data in program design, theory-based programming, including their application in social and behavioral change communication and health system strengthening. He has conducted and published extensively on multiple health topics, including family planning, sexual and reproductive health and rights, among others. Our last but certainly not the least speaker is Mrs. Adedoyin Roberts. Adedoyin has more than 6 years experience in conducting research, monitoring and evaluation related to reproductive health, education and development programs and projects. She holds a bachelor's degree in demography and social statistics from Obafemi Awolowo University and a master's in public health from the University of Ibadan, Nigeria. Currently working as a research monitoring and evaluation officer for the JHCCP-led post-pregnancy family planning project. So I'll hand over to our lovely panelists to take on the next session.
Thank you, and good morning, everyone, or good afternoon, wherever you are. So this morning, we're going to be talking about the design and sharing some of the findings from the evaluation of this project. We're going to look at what the project was all about very succinctly, what the RMEL design was, the methodology for 2 of those components, and we're going to share also findings from 2 of the components, that is the household survey and the health facility assessment. Then there'll be some general discussions and questions and answers. Let me start by just, talking a little bit about what the project was all about. So the project adopted a 3-pillar intervention model that focused on advocacy, on demand generation, and service delivery. Advocacy-related efforts sought to create an enabling environment for demand generation and service delivery, while engaging with all relevant stakeholders, irrespective of their beliefs and sensitivities. The demand generation pillar was theory-driven and used multiple channels to disseminate culturally sensitive messages that address issues and concerns around family planning. Then the service delivery efforts were designed to strengthen the health system by improving quality of services, of family planning services. Now I'm going to talk about the methodology. The RMEL design for the PPFP project was rigorous and comprehensive. It includes data collected at multiple levels, including through a household survey, through health facility assessment. We also had a program management information system. And then there was a panel survey where we recruited pregnant women and followed them over time for about 18 months. I'm going to talk about today, because today we are not focusing on the panel survey. That was going to be the object of another webinar. So please watch out for the invitation, and we hope to see you there. Today we're just focusing on the household survey, on the health facility assessment, and on the PMIS. So the household survey was designed to gather data to guide program design and implementation, to monitor the reach of our communication programs, to also assess the association between the demand generation activities and intermediate outcomes, including ideational variables that we're going to be talking about later. Now, the survey design was rigorous. It included selecting participants following a multi-stage approach. So it targeted pregnant and post-pregnancy women ages 18 to 49. The sample selection was started with selecting 10 LGAs. In each LGA, we selected 12 enumeration areas. And then in each of those enumeration areas, we selected 10 household, 10 eligible household. That is an household that includes at least a woman that is either pregnant or that had a child within the last 12 months. The baseline, next slide. The baseline was implemented in 2018 and the end line in 2020. Of course, as with all the research activities that we carry out, we obtained ethical approval from the Lagos State University and the Johns Hopkins University IRB. Sample size was 1244 at baseline and 1,347 at end line. For the health facility assessment, the objectives were to assess preparedness of high volume sites to provide quality integrated services. We were also interested in describing the processes that providers follow as they provide family planning, counseling, and services to their clients. We wanted to document the extent to which family planning services are integrated into other MNCH services. We are also interested in identifying the gaps in equipment, in training, in commodity and resources needed to offer quality family planning, counseling, and services. And finally, we're interested in understanding clients' perspectives on family planning services received. So again, the design was we targeted all the high volume facilities at baseline and end line. There were 3 components to this assessment. Again, you know, it's a nested design. So we had health facility audits to assess availability of equipment, of services, of supplies, of manuals, of IEC materials, to also understand staff cadre and training, the extent of service integration, client volume, and other indicators. We also conducted provider interviews to assess provider training, their competency, their counseling skills, the bias that they have, their workload, and so on. So we conducted 537 interviews at baseline and 407 interviews at end line. Finally, as part of the health facility assessment, we conducted client exit interviews that targeted women receiving MNCH, reproductive health and family planning services, and this focused on their experience on the day of the visit, the perceived quality of services, client satisfaction, among other things. So the baseline, again, for this was conducted in 2018 and the end line in 2021. Again, we obtained ethical approval as was necessary. Finally, the program management and information system was implemented at the service delivery level, the demand generation level, and the advocacy level. At the service delivery, we tracked family planning uptake, we tracked method mix, commodity stockout, and referral system. We also tracked the number for demand generation, we tracked the number of spots that were held, the number of clients reached during events, and the referral during in-clinic mobilization and facility-led outreaches. For advocacy, we tracked the number that were reached, the number that was reached through advocacy-related activities and, you know, exposure to religious leaders and activities at the places of worship. I will now pass the baton to Mr. Akin to tell us about the key findings from the household survey. Thank you.
Thank you very much, Prof, for that very detailed presentation. You have done most of my work providing very detailed methodology for these components of the survey. Next slide. This slide here shows us the demographic characteristics of the post-pregnant women that were interviewed as part of the survey, both at baseline and at end line. The key message I'd like to promote here is the fact that, as you can see from the age, religion, and other variables from those distributions, you will see that the women that were interviewed at round 1 and round 2, that is baseline and end line, were very similar, as you can see. Next slide. The first key result here is that we compared contraceptive use method mix across baseline and end line. And as you can see, one of the efforts one of the communications from the PPFP project is the fact that lac use within the post-pregnant period is safe for women. And as you can see, between baseline and end line, you see that the proportion of women, post-pregnant women who took up and using implant doubled between baseline and end line. We also try to look at service utilization at the private sector. Like we know in the past, family planning services were perceived not to be available in the private sector. One of the communications from the project is the fact that everyone can access family planning services from the private sector. And as you can see from this slide, at baseline, you will see that the proportion of post-pregnant women who reported to have sourced their current family planning in the private sector are doubled, increasing from 9.8 to 22.2%. We then try to look at women who said they were not using contraceptive at the time of the survey. And as you can see here, these are the different reasons that were given by the women. Most of them, as you can see, range from those who said they are not using because they recently had a baby. About 1/3 of the women said this. While other reasons are also presented and as important, you will see that close to half of the women said they were not using family planning because they were breastfeeding. And so this created some questions in our mind to try to ask women, because if you are not using family planning for these two reasons, we thought, could you be using LAM? So we asked questions about knowledge of LAM. And as you can see, only about 1 out of every 5, 1/5 of the women that were not using were aware of lactational amenorrhea method. So this is something we found really important, because the other 4 out of the 5, how come they do not think they should be using some sort of family planning at this moment? Next slide. On this slide, we try to capture some of the information around exposure to family planning information on radio in the last 6 months before the survey. And as you can see, about 1/3 across board, both baseline and end line, post-pregnant women, just about 1/3 of them said they have heard family planning information on radio in the last 6 months. This next slide tried to look at other sources of information that are mostly used by post-pregnant women in Lagos. This result here showed that Facebook among social media platforms were the most used by post-pregnant women as reported in our survey. And we asked this question both at baseline and at endline. This result showed that at endline, the proportion of women who reported use of Facebook was the most reported to be used, followed by WhatsApp. And as you can see here, our results show that only 1 out of every 5 of the women who said they use Facebook reported that they have seen family planning information on Facebook in the last 3 months. So the question would be, what does it cost to put information on Facebook? And how can this really profit programming? Next slide. The other type of exposure that we looked at were some of the exposure around radio, around family planning on radio that were aired by the project through radio spots. And as you can see here, we have different type of spots that were heard, and they were addressing different topics, as you can see. And across board, you will see that exposure to these spots across the survey rounds increased from baseline to endline. So the next set of slides are something that is really important as we go. I think the question that we need to be looking at is, in terms of results, with all these results that have been presented so far, what really has really changed in terms of the work that the PPFP project has been doing? Recall that the previous speaker have talked about how the project's efforts at the 3-pronged level were rolled in and rolled out using the ideation lens. So the question here then is, how have we impacted ideation? How have we improved intention? And how have we improved contraceptive use at the population level through this project in Lagos State? So the question that then comes to mind is, when we say, how have we improved ideation? The question will be, what then is ideation? As you can see here, ideation refers to the beliefs, ideas, and feelings that people hold about specific behaviors. The ideation model says that when you change the ideation factors of people, that you will change their behavior, that their behavior will change. What does this mean for family planning? It is not sufficient to say, oh, you must use family planning, or you should use family planning. If we do that, nothing changes. But the ideation theory has provided a behind-the-scene approach to improving behavior, including contraceptive use behavior. So what this means is that if you want me or a population to use contraceptive, the ideation model is saying, focus on the beliefs that they hold about family planning. Focus on the ideas and focus on improving the feelings about family planning. This model is saying, if you improve this, that you would have improved the behavior. Next slide, please. Over these years, the project of the Johns Hopkins University Center for Comprehensive Programs have been identifying different additional factors that can improve contraceptive use. And on this slide are some of them, as you can see: contraceptive knowledge, misinformation. If you improve that, you can improve contraceptive use. If you improve contraceptive awareness, if you improve peer behavior, if you improve self-efficacy, if you improve spousal discussion, this model is saying that when you pull all of these together, as you improve them, that you will be improving contraceptive use. Next slide. So the question then is, how has this ideation that the project has been trying to improve, how has it changed over time? As you can see from this slide, there has been significant increase in these key ideational factors between baseline and endline. I am not going to go through them each one after the other, but you can see that awareness of modern family planning methods as an additional factor had increased significantly. Rejecting myths and misconceptions about contraception, especially in the post-pregnancy period, the rejection of more of these myths also almost doubled, as you can see, and so on and so forth. So you can see that the project has significantly improved additional factors between baseline and endline. Next slide, please. Also, we tried to look at intention in the post-pregnancy period. We wanted to know among post-pregnant women, how has intention to use family planning between baseline and endline increased? How has it increased? And as you can see from this slide, there is significant increase in intention to use in the post-pregnancy period amongst post-pregnant women in Lagos. Next slide. On this slide, this table here, we try to understand the relationship between exposure to family planning, to PPFP, SBC's materials and intervention, and ideation. In this table, we fitted 7 models and we adjusted for age, education, and number of children that were ever born. As you can see, the model suggests that exposure to post-pregnancy materials from the project were significantly associated with increased odds of family increased family planning discussion with spouse, discussion with family size, and personal advocacy. Specifically, you will see that women that were exposed to family planning PPFP SBC materials, they were 79% more likely to report higher odds to discuss family planning with spouse compared to those that were not exposed to PPFP project SBC materials. And the result, same result goes for discussion of family size, and of course, personal advocacy. Next slide. On this table, we fitted 8 models. On each of these models, we also adjusted for age, education, and children that were ever born. And these results here suggest that women who were contraceptive use were significantly associated with a number of additional factors on this table. These additional factors include, as you can see, increased knowledge, discussion with spouse about FP in the last 6 months, personal advocacy, rejection of myths and misconception, and of course, perceived self-efficacy and perceived peer behavior. This result means that as you can see, that women who are using contraceptive, they are at higher increased odds of having these additional factors here that were significant compared to those that were not having these additional factors. Next slide. So here I'm going to invite Mrs. Adedoyin Robert to continue with the presentation. Thank you very much.
Thank you very much, Mr. Aki. Very quickly before Adedoyin comes up, just to ascertain our level of attentiveness during the previous presentations, we have 2 simple questions for you to attempt. Just within 10 seconds. You should be seeing it on your screen now. So the first question, the women interviewed during the household survey are, is it women of reproductive age? Is it the post-pregnancy women? Is it none of the above? And the second question, the health facility assessments that were conducted in, is it the public health facilities, the private health facilities, or none of the above? And the poll will end in 10 seconds. I start my counting now. 10, 9, let's keep it coming. I can see more people are trying to vote. 7, 6, 5, 4, 3, 2, 1, and that's the end. We're launching the results Thank you everyone for voting. We can see how we fare. I think we did well with the second question because we know that the post-pregnancy family planning project worked within the private sector, private health facilities to be specific. And for this one, we are all about the post-pregnancy women. It means both the pregnant and even after delivery, from the moment of conception up until 12 months post-delivery. So I'll leave it to the RMNE team now as I hand over to Adedoyin. Thank you everyone for voting.
Yes, thank you, Mercy. And thank you to Mr. Aki and Prof for a wonderful presentation so far. Okay, so for the next set of slides, I'll be talking about the findings from the health facility assessment across private facilities in Lagos State. But before I talk to that, I would quickly like to reiterate the objectives of the health facility assessment, just like Prof has said in our presentation. So one of those objectives was to assess the preparedness of the private health facilities to offer quality and integrated family planning service. Another was to identify those gaps when it comes to availability of resources and equipment needed to provide quality FP service. Also, one of it was to understand client perception when it comes to FP service provision, as well as their satisfaction with the quality of service that is being received across these private health facilities that was assessed. Okay, so now we will be looking at the findings, the key findings from those assessments. So between the baseline conducted in 2018 and the end line that was conducted in the first quarter of this year. So in terms of the types of services provided across these private health facilities assessed, we see that more private health facilities are now providing FP counseling and services. So we have an increase from 90.5% to 100% when it comes to provision for FP counseling and services. Also, like we know that the availability of good equipment and infrastructure in general within the health system or within the health facility is very key when it comes to maximizing the effectiveness of care being delivered. We could see that there is a significant improvement across all the facilities assessed when it comes to those resources that are needed to support delivery of quality FP services between the baseline in 2018 and the end line that was conducted early this year. We see majority of the private health facilities reporting to have a dedicated family planning space. Also, in terms of methods, availability of the different FP methods, we know that when women have access to a full range of methods, we are able to also reduce and address the issue of missed opportunities for women. There is also, we found out that there is a significant improvement when it comes to the availability of methods across, so for all methods, we see an improvement across all the facilities that were assessed. While we know that when the capacity building and competency-based trainings for service providers, especially for with regards to family planning, we know that that goes a long way to helping providers do better and provide better services when it comes to family planning. Between the baseline and end line, we could see that there is also a significantly higher proportion of providers who reported to have received different trainings in-service training for FP, especially for interpersonal communication and counseling, the long-acting reversible contraceptive, and also for the contraceptive logistic management between baseline and end line. For the use of job aids across the private facilities that were assessed, we have more and more providers making use of the FP counseling job aids, especially when they are seeing their antenatal care clients and also the clients that comes for postnatal care, as well as those that came for post-abortion care services across the different facilities that were assessed. For the providers who reported that, so I will relate this slide to the previous slide on in-service training. While there has been an increase in the number of providers who have been trained on the different types of having received different types of in-service training, we also have a significantly high proportion of service providers who reported that they are now highly confident to provide or to offer contraceptives between the baseline in 2018 and endline that was conducted this year. In terms of attitude towards contraceptive use for various categories of clients, we have more providers, more service providers agreeing to facts and general statement around providing to various categories. So for instance, we have more providers saying that yes, they agree that a woman can use contraception even before she starts to have children. Also that antenatal care clients should not be denied having access to FP information. Women who brings their children for immunization should be given a method of choice as well. So this is also similar to what we've said before now. More providers are agreeing to such statements that yes, they wouldn't mind their children allowing their teenage friends to be friends with an unmarried woman who is currently on a contraception, a form of contraception. So there was a significant improvement as well with respect to that. And for perceived attitudes and behavior towards providing contraceptive, we also see across all the different variables that was assessed between base and end line, there is also that significant improvement in terms of how providers are perceived providing methods of contraceptive service to women who comes to access such services at the different private health facilities. Now, what about provider bias? So the next 2 or 3 slides will be talking about provider bias. And by provider bias, it simply refers to attitudes, behaviors that is being exhibited by providers. So it means providers when they unnecessarily restrict clients' choice and method due to the client's characteristics or the method itself. So when a provider restricts offering a method to a client based on some characteristics or based on the method's characteristics, it simply implies that the service provider is biased in that particular instance. So we looked at bias in 3 different forms. We looked at providers who were biased as because of age. So we looked at it also in respect to marital status. We looked at it in respect to parity, that's the number of children a woman has had. So if a woman has had a particular number of children, if a provider insists on not providing or offering contraceptives to such women due to the number of children, then it means that a provider is biased when it comes to parity. also the same for age and for the other categories. So with respect to the age of a woman, we between the baseline and the end line, there is a significant decrease across all the different methods, though the decrease was minimal, but then there was a decrease across all the methods, whether short-acting or the long-acting methods. And for parity of a woman, there is also that, yes, a good proportion, that large proportion of providers. Also, we had a decrease as well across all the various categories of methods that is being offered to women. Same for the marital status. For a woman who says she is unmarried, we have quite a number of proportion of providers who still hold these bias when it comes to offering methods to women, though there was that significant decrease as well between baseline and endline across the different private health facilities that was assessed. And as I begin to wrap up my session, let's look at the client angle to it. What are the clients that were accessing these different private health facilities? Let's look at their perception of the kind of services received, especially for family planning, and as well as their level of satisfaction when it comes to services being provided across these different private health facilities assessed. So in terms of awareness for family planning services, there was a great increment, significant increase between when we assess these facilities at baseline from 56% to over 88%, and it was significant for women who are non-FP clients. So more women are getting aware rather that FP is being provided across these different facilities. In terms of the information received during the major maternal newborn child health care services across the different facilities, there was also that significant increase. So more women reported they were told about FP while they were receiving other services. And of course, for client satisfaction, there is also an improvement. More clients are satisfied with the kind of services that was received across these different private health facilities. And lastly, to wrap up my session, the PPFP Program Management Information System for those that were reached during major social mobilization activities, we were able to reach over 170,000 women with family planning information, and of course referral was as well on the high side. So 8 out of every 10 persons that was reached were of course women. And for contraceptive uptake across these different private health facilities that were assessed, there was an increase looking at where it all started from in April 2018 to where these facilities are right now when it comes to uptake of family planning services across those different facilities. There's been a great increase looking at where they started from and where these facilities are now, meaning it means that more women are accessing services and then more women are also uptaking service. So I would like to hand over the baton now back to Prof, who would lead us into the next couple of slides. Thank you.
Thank you so much, Akin. Thank you so much, Doyin, for this wonderful presentation. So I'm just going to wrap it up and look at what we have achieved and what we still need to do. As we have seen, this multi-pronged project has had noticeable, demonstrable impact. Next slide. So there is no gainsaying the fact that a lot has been achieved over the past few years of the lifespan of the project. we saw that, you know, data from various sources suggest impact on service delivery as well as on the intended population. Data from household survey indicates improvements in additional characteristics of pregnant and post-pregnant women and between baseline and endline. We also saw that exposure to program communication materials was average, but it has increased over time. Exposure to communication materials was associated with increased odds of demonstrating positive additional outcomes. In addition, we found that significant increase in availability of equipment, availability of resources for quality services, and availability of commodities between baseline and endline, as demonstrated in their facility assessment data. We also found significantly higher proportion of providers who had relevant training and who use appropriate job aids during counseling, higher proportion at baseline, at endline compared to baseline. We also found that provider ideation and elements of provider bias, provider ideation has improved and elements of provider bias has declined. But the battle is not over. There is still more work to be done. We see that, yes, provider bias has declined, but it is still very much there. We also need to intensify efforts to reach more men and women of reproductive age with PPFP related messages. There is room for improvement in the provision of family planning information while people are at the facility for that service. It is not yet systematic. We need to make it systematic. More efforts are also needed to promote immediate adoption of modern methods, especially long-acting reversible contraceptives post-pregnancy. We also need, now the question is, yes, we've achieved a lot, but we should ask ourselves about sustainability. So efforts are needed to ensure sustainability of the achieved improvements and also to scale up this very successful project. Thank you. So we are now going to take the questions and comments, and we'll try to provide answers to your questions.
Thank you very much, Professor. Thank you very much, Mr. Akiade, and thank you very much, Adedoyin Roberts. Now we go on to the questions and answer session. We have a few questions here, so please keep the questions rolling. I'll just take the few ones that we have here and leave the RM and E team to answer the questions. So the first one, why is it that ladies prefer the male condom than the female condom? Why is it that ladies prefer the male condom than the female condom? Another one says, why do we have low IUCD uptake? Another one says, with regards women who were not on family planning because of recent birth, what time frame was used to represent the term recent? And did knowledge of anovulatory cycles after birth play any role? I'll take the last one and hand over to the RM and E team. Said, is there any analysis or result to show the effectiveness of the PPFP intervention? How comparable is the desired change at the onset of the project to the actual change in the result presented today? Is there any analysis to show for that? Can we have the RM and E team answer?
Oh, okay, I will take I will take the first one, and maybe one or two others, and then I'll allow my colleagues to go ahead and answer some of the other questions. So for the first one, why is it that ladies seem to prefer the male condom to the female condom? I do not think that ladies prefer the male condom. You know, it takes two to tango. So the man is the one who uses the male condom. So maybe the question is, why is it that men prefer the male condom? So I think it's, you know, it's whatever the couple decides to use. And I do, if we are familiar with the literature, the woman doesn't have as much power in sexual negotiation as the man. So I think that this is not about the female condom being preferred, it's about the male condom being in the domain, not of the woman, but of the man. I don't know if that answers your question. And then the question with regard to women who are not on FP because of recent birth, what time frame was used to represent the term recent, and did knowledge of an ovulatory cycles after birth play any role? Yes. So that question, that is a very good question. Thank you. But you know, the recent is the way they see recent. For one woman, recent might be, or just had a bath yesterday, but for another person, recent might be that, you know, they had a bath in the last 3 months. But you know, the truth is that we need to increase the understanding, you know, about ovulation, the understanding about the fact that, you know, a woman might have a child yesterday, and she's probably, you know, within 1 month of birth, of the birth of delivery, she might actually conceive, and that PPFP methods are safe. So we really need to increase that understanding so that women do not continue to give recency of birth as an excuse for not adopting a family planning method. So that's part of the work that still needs to be done. I'll let my colleagues choose which ones they want to answer. Akin, over to you.
Thank you very much, Prof, for setting the pace. And of course, thank you very much for the response to that question on recent. I will speak to the questions on what the projects have been able to achieve. I don't know whether the person who asked the question joined the webinar while I was presenting, but if you look at the last 2 set of slides if you look at all the slides generally and then look at the last 2 set of slides where we modeled and fitted in one place about 7 models and the other one about 8 models were fitted. And in those points, at those points, what we try to look at is how exposure to PPFP interventions have impacted ideational factors of post-pregnant women. The second part of that question was what did the project set out to achieve, and how is that different from what we saw in terms of our results? The goal of one of the things that the project tried to achieve is to improve the contraceptive behavior of post-pregnancy women in Lagos. And that was what was addressed by those last set of models, showing the association between being exposed to the PPFP interventions, especially the SBC materials, and how that impacts ideation. We also did show the relationship between contraceptive use and improved ideation as part of those results. Those were some of the key results that we wanted to achieve. Those were some of the intention results that we wanted to achieve. The last other thing I will mention is in the area of service delivery, or in terms of health system strengthening. The project, one of the things this project wanted to improve was to improve the capacity of the private sector facility to deliver quality service. And from some of the presentations, from the results from Doyin's presentation, you will see how the project have been able to impact many of these facilities in terms of strengthening. Many of those facilities can now offer quality family planning services, and the results showed how this improvement had changed from baseline to end line. So we also, Doyin did also make some presentations around provider ideation. Some of the hypotheses at the beginning of the project was that if we improve provider ideation, that providers are going to offer better quality service. And as you can see again from our presentation, from those slides, you will see that there is significant improvement in provider ideational factor in terms of the, one of them that was in terms of attitude to women using, pregnant women using family planning, and of course, other provider-related ideational factors. So those are some of the results that we could quickly point to in terms of what the project was able to achieve. Thank you very much.
Okay, so I would be taking the question from Toriola Bukola. Thank you for your question. So for the 18,000 plus women who received family planning, you wanted to know if it was disaggregated for lack. That's to know those on PPIUD and implant. So you wanted to know if we disaggregated long-acting and short-acting method. So because these are post-pregnant women, definitely the uptake included lack. But then it's, so yes, that was not shown in this presentation, but that uptake definitely includes those women uptaking lack within the immediately after, and yes, within the postpartum period. So it includes both. It captures those, but then it's not being shown. But then thank you for that question.
Thank you very much. We'll take the next set of questions. One of it says, what are the plans to sustain the gains made by the PPFP project in Lagos State? Another one says, I want to ask why people are not taking the emergency contraception. And then from Nathaniel, we have, is there any result or analysis that shows the effectiveness of the PPFP intervention? How comparable is the desired change at the onset of the project to the actual change in the result presented today? Is there any analysis to show for that? And then we take one from Kehinde. What benchmark did you use as baseline in this study? Was it based on the number of women who were followed up from delivery? We have one from an anonymous attendee. Did the project track personnel or other people? Did it track FP method failure and how this influences ideation and future method choice? From Adaura, we have, was there any study to compare the attitude of married post-pregnant women with unmarried post-pregnant women with respect to uptake of family planning? And lastly, we have from Hamed, more of a comment or food for thought. So he says, I'm a bit worried that as high as over 60% of providers are still restricting access to family planning methods even after training. Could this be a challenge with our training curriculum, methodology, or trainers? How do we make this better? Over to you, RM Annie.
Okay, I think I would want to agree. Yes, want to agree that yes, there is still a lot to do for Ahmed Adediran. Thank you for that comment. There is still a lot more work to be done when it comes to provider bias. Yes, it's something that is still quite very high. And of course, obviously, training curriculum and methodology is something we might want to look inward, not just for the private health facilities alone, but even across, because it spreads beyond this issue of bias goes beyond just the private health sector, though the prevalence might be a bit different when we look at the public sector and the private sector. So yes, it's something that is definitely something we should look inward to see how best we can tackle it. Yes, provider bias reduced, but then it's still very quite high, especially for age of a client. So I would allow Prof and Mr. Akin to shed more light on this, because I believe this is an issue that we shouldn't just overlook. It's something that is very, very key when it comes to ensuring that women have that access to a contraceptive. We don't deny them of that privilege.
Okay, if I may jump in there. Okay, I can
go ahead, ma. Prof, okay. Go ahead, ma.
So if I may jump in there, I think, yes, I agree with you, Doi, that this is a very pertinent question. Now, the thing is, yes, we all know that training alone is not nearly sufficient to tackle things like, ingrained. So it takes time, it takes other approaches. It takes also looking at the training. It shouldn't be just about edge knowledge, but actually, values clarification and all of that. So we need to rethink the training. We also need to probably do more in-depth, maybe do a qualitative type of research, or adopt HCD approach to see what exactly are the issues, and then devise ways to tackle the issues. So something, we all agree something needs to be done. Maybe more research is needed. We need to rethink training, maybe the curriculum, but also the approach to training. I will take two of the questions, one from Nathaniel, and then the other one that was talking about what are the plans of Lagos State. I saw that now, but it's now disappeared from my screen. But so just to say that, for the plans to sustain the gains, that should be for Lagos State to answer. So we'll leave that to Lagos State to think and come up with ways. I'm sure that they're already thinking about this, but that's something also that CCP could help them with. Yeah. So then the one from Nathaniel says, is there any analysis result to show the effectiveness of the PPFP intervention? How comparable is the desired change at the onset to yes, those are very important issues to ponder on, and we have those results in the study report, but on the tip of my hands, I don't have them. These are things that we can share with you, and maybe Doyin or Akin can say something about that. Then there is another one about following up on women on women with contraceptive failure. That was not done as part of the results that were presented today, but we have answered to that in the longitudinal study that we are going to be presenting in a few weeks. So please be on the lookout for the answer to that.
A big thank you to our panelists. Mr. Aki. Hello. Yes.
Okay, can I speak?
Yes, you can speak now.
Okay, I wanted to add to the response on provider bias, just to quickly say that provider bias, transcends the clinic. It transcends the clinic setting. So clinical trainings are not enough. So several studies are beginning to explore why these biases are there, and some of them are showing that the reasons why providers restrict provision of certain methods for certain set of people is not because they want to be, they do not want to offer that service, but sometimes some of these attitudes are protective in nature. Sometimes they are based on norms that they hold and so on and so forth. So like Prof have said, the topic needs to be studied more to get beyond the clinical factors, no other behavioral dimensions of this practice in order to solve that problem. And the interventions that we reduce them also transcends clinical trainings. Other behavior change interventions will be required, just to add my voice to that. And to also respond to a part of the question from Mrs. Kehinde Oshinowo about which, how I think maybe she didn't get part of the methodology that was presented, but that what we presented today was from a cross-sectional survey with a baseline and end lines of cross-sectional household survey. And then the other one was from the health facility assessment that has both provider, facility audit, and clients components. So those were what we used to compare at baseline and end line, just to respond to that. Thank you.
Thank you so much, Mr. Aki, and to Prof and Doyin. A big thank you to all our panelists and for everyone that's joined us today. So we'll have other upcoming events, end of project dissemination series, and we hope you will definitely join us. We have one next week where we'll be showcasing our achievements more, and you will hear live voices from the field. So we do hope you started registering and you join us. And we also have another one on the longitudinal study itself. So it's going to be rich, detailed, and promises to be interesting. So we do hope you join us. And we are so sorry for the camera issues at the beginning, and we do hope that next time we will join in on time. Thank you, everyone. A big thank you to everybody that has joined today. And a special thank you to our keynote speaker at Radio Diallo, and to Dr. Mojisola Odeku, and also to every member of the Lagos State, of key officials of the Lagos State Ministry of Health and Primary Healthcare Board that have joined us today, and also all our supported private health facilities and the private sector associations. And we have come to the end of the webinar. Thank you, everybody.
Thank you.